Good day, everyone. So, this is a lecture on pulmonary gas transport. So, we're going to be talking about the gas journey. So, we'll be discussing about the pulmonary gas transport, and we're going to explain on how the oxygen move from the atmosphere into the body and how the carbon dioxide is removed. So, we're going to talk a little bit on how the air moves into alveoli, then how it moves to the blood, then how it moves to the tissues before it is returned back to the lungs. So by the end of this lecture, you should be able to explain the entire journey and relate to it clinically. Before we begin, let's start with a case scenario. A 65-year-old man who presented to emergency department with acute short of breath, which on examination, he was tachypneic with low oxygen saturation. So this patient is breathing rapidly but still remain hypoxic. So why does breathing more do not solve his problem of oxygenation? So in order to answer this, we need to understand how the gases moves through the body. So these are the learning objectives, where you're going to cover a little bit on the composition of air and how the gas exchange happen between the alveoli to the blood vessels and vice versa. Then we're going to talk a little bit on how the gases are transported, particularly on the oxygen and carbon dioxide. Fourthly, we're going to talk a little bit on the factors that can influence this process. Now, looking at the composition of air, the atmospheric air here contains about 21% of the oxygen in the green box and has a very little carbon dioxide of about 0.03%. But once this air reaches the alveoli, the composition changed, where the oxygen dropped slightly with a higher concentration or percentage of carbon dioxide, which you can see in the blue box. So these are the partial pressure for each of the percentage of air. So notice that the alveolar oxygen is much lower than the atmospheric oxygen. So why do this happen? So from inspired air through to alveolar air and expired air, this air undergoes a humidification and it undergoes a continuous gas exchange throughout the respiratory tree, and the air that has entered from inspired air through to the alveolar has mixed with the residual air. So what matters now is not how much of the oxygen in the air that you breathe in, but how much of the oxygen that reaches the alveoli for them to undergo the gas exchange. So now, what are dead space? So to understand the concept of dead space, we must first understand that not all inhaled air participates in gas exchange. So some of the air that we inhaled remain in the conducting airways, whereby these are known as the dead space. So to further understand on dead space, we must first establish our understanding on minute and alveolar ventilation, the VE and VA. So minute ventilation is the total of air that enters the lung given by this equation on the left, and the amount of air that enters the lung in one breath is known as the tidal volume, or the VT, which usually equals to 500 mils. Hence, this formula is used to calculate the minute ventilation shown in this slide. So despite that, only alveolar ventilation that contributes to gas exchange, which means not all of the tidal volume that enters the lung will be involved in gas exchange, where some of this air will remain in the conducting zone, or otherwise known as the anatomical dead space. So therefore, the alveolar ventilation, the VA, will always be lesser than the minute ventilation. So let's say if you breathe in a smaller tidal volume lesser than 500 mils, which means most of the air will stay in the dead space. So there will be a lesser amount of volume of air that will enter the alveolar to allow for gas exchange. So how many types of dead space? So there are two types of dead spaces, which are anatomical dead space and alveolar dead space. So in combination, they makes up the physiological dead space. So anatomical plus the alveolar dead space equals to physiological dead space. So this illustration beneath here, down here, shows the movement of old and fresh air during one breath in and out. So now, let's say if our patient breathes rapidly but shallowly. So let's just wait for this illustration first. So now, let's say we have a patient that breathes rapidly but shallowly. Will the gas exchange be efficient? So the answer to that will be no, because the dead space will occupy a larger proportion of it. So looking at this formula here, the VA equals to VT times RR minus DSV times RR, where DSV is the dead space volume, the total dead space volume. So increasing the respiratory rate here alone with lesser tidal volume will cause a lesser or inefficient alveolar ventilation, which means more air will occupy the dead space. So the simple answer to this question, whether the gas exchange is efficient or not, the answer is no. So the gas exchange is not efficient, which means not all of our rapid breathing are useful breathing. So these additional notes on the dead space, where we have a pulmonary shunt. So this based on Dr. Miat's lecture on the VQ mismatch, which will be less dominant or prominent in healthy individuals, whereby if somebody have a lung disease, so the compensatory mechanism causes the VQ mismatch to be more prominent. So the effect will become a little bit more apparent compared to people in normal lungs. So now let's move to the gas exchange. So once the inspired air reaches the alveoli, an exchange will occur. So this exchange occur in the respiratory zone, mainly in the alveoli. So the respiratory membrane is extremely thin. So, and this will allow a rapid diffusion of gases from alveoli to blood vessels and vice versa. So these are the six layers of the respiratory membrane, the thin respiratory membrane. So it goes from the surfactant to the alveolar epithelium, pass through the epithelial basement membrane, then it goes to the interstitial space, the division between alveolar and the blood vessels. Then it passed through the capillary basement membrane, then passed through the capillary endothelium before it enters the plasma or the blood vessels. So this oxygen moves from the alveoli to blood because of high partial pressure in alveoli, as seen in this diagram, where the PO2 in the alveoli is P equals to 100 mmHg. So meanwhile, for the carbon dioxide, it will move in the opposite direction, as the deoxygenated blood seen in these blue blood vessels contain more carbon dioxide. So therefore, we can say that the diffusion will occur down the pressure gradient. Then this gas diffusion will occur rapidly, where it takes only 1/3 of the vessel length to equilibrate. So which means the remaining length serves as a reserve for gas exchange during the stresses, such as when you undergo exercise or when you are in respiratory distress. So in other words, it acts as the backup system when needed. So the blood vessels is just simply passed through 2/3 of the blood vessel length without doing any exchange. So now let's get back to our patient here. So why are the patients still low? So despite having tachypneic with rapid and shallow breathing, and the chest X-ray has now revealed that he has a pulmonary edema. So because of this pulmonary edema, it has increased the membrane thickness of the respiratory membrane. So therefore, the problem with this patient is not about the ventilation, how massive, how rapid he breathes, but it's a diffusion problem. Okay. So this diffusion depends on 4 main factors. So based on Fick's law, as you have learned in blood flow as well. The first one is the partial pressure gradient. Second is the thickness of the respiratory membrane. Third will be the total surface area, both capillary and the alveolar. And fourthly is the diffusion coefficient, where carbon dioxide dissolves more better than the oxygen. So therefore, in pulmonary edema, as seen in the patient, the membrane thickness has increased through existence of additional fluid in the interstitial spaces. So therefore, we can say that the oxygen, despite being present, but it cannot cross efficiently, causes a poor or inefficient oxygenation of the blood. So now this is how the oxygen being transported. So once oxygen is inside the blood vessels, oxygen can be transported in two forms. Through very little will dissolve in the blood plasma, which gives you the partial pressure of oxygen. But massively or majority of the oxygen will be bound to hemoglobin 98.5%. So why do we need the hemoglobin? So without this hemoglobin, the oxygen delivery would be very insufficient. So now let's say if we have a patient that has no hemoglobin, will the oxygen delivery be adequate? So according to this equation and this calculation, the oxygen delivery will not be adequate or will be insufficient. So our normal resting cardiac output is usually 5 liters per minute, as you can see here on the left. Therefore, without this hemoglobin, only 15 mL per minute of oxygen can be delivered to our body tissues, which is not adequate and does not meet up the normal tissue consumption of oxygen, which is equivalent to 250 mL of oxygen per minute. So therefore, hemoglobin is very extremely essential for our body survival, especially in delivering the oxygen. So let's say we do not have any hemoglobin, then we need a cardiac output of 83.3 liters per minute in order to deliver sufficient oxygen to the body tissues. So these are just the summary of the hemoglobin function, which you can also see or read your notes back in block 3. This is about the oxygen carrying capacity, which you can read later on. So now this is based on our patient earlier, where this existence of pulmonary edema, limited oxygen inhalation that needs to bind to hemoglobin will be efficiently transported. So therefore, in any of the patient, in anybody, in any individuals, hemoglobin is essential and most crucial component for oxygen delivery. So now this is known as the oxygen hemoglobin curve. So this graph shows how the oxygen binds to hemoglobin at different partial pressure. So partial pressure is on the x-axis, the hemoglobin oxygen saturation is on the y-axis. So to simplify, this oxygen hemoglobin curve simply shows how easy the hemoglobin pick up oxygen or how easy the hemoglobin to release the oxygen depending on the oxygen level. So this oxygen dissociation curve is sigmoidal in shape. In simpler words, this graph shows that hemoglobin picks up oxygen at high PO2 environment, such as in lungs, and releases the oxygen in low PO2 areas, such as at the body tissues. So this sigmoidal curve is present due to the positive cooperativity of the hemoglobin, whereby when one oxygen molecule has bind to the hemoglobin will change its shape, making it easier for the next oxygen molecules to bind. So this is what known as the positive cooperativity phenomenon. So as PO2 increases, as you can see from this x-axis, from blue going to the red, as the PO2 increases, the hemoglobin saturation rises rapidly, where you can see the steep curve in the graph. So steep curve in the graph here goes up rapidly. So at this steep region between 20 to 60 mmHg, a small rise in PO2 will cause increase in hemoglobin saturation. So now let's see what happened at the lower PO2 of less than 15 mmHg. So there will be no bound oxygen if the PO2 is lesser than 15. So if it's lesser than 15, so there will be no bound oxygen. So meaning that the hemoglobin now has low affinity to oxygen, so low attractiveness to oxygen. So even if the PO2 at this level increases slightly, perhaps up to 20 mmHg here, so there will be very little increase in oxygen saturation. So the likelihood of the oxygen to bind to hemoglobin will still be very little. So the empty hemoglobin is reluctant to bind to oxygen. So therefore, clinically, this oxygen therapy, if you give oxygen therapy, raising the PO2 substantially, allowing the hemoglobin to enter the positive cooperativity zone, and then you can lead to increase in oxygen saturation. So that's why in our patient, we tend to treat the hypoxemia patient with high oxygen unless it is contraindicated. So by giving them extra or high oxygen therapy, it will help the hemoglobin enter this positive cooperative phase in order to help the oxygen bind better to hemoglobin. So now, when you see here in this slide, you can see the reduced slope at PO2 between 60 and 70, 60 and 80. So here, so where this is the transition zone, and at this stage, at this zone, the hemoglobin is almost full. So hence, the binding will become slower. So because dia dah nak full, almost full, so therefore the binding of oxygen will become lesser. So then it proceeds to become the plateau phase between the 80 to 100. So 80 to 100 here, mmHg. So therefore, the hemoglobin is now already 90 to 100% saturated. So therefore, increasing the PO2 further will only cause a very minimal increase in oxygen saturation, because most of the hemoglobins are now fully booked. So this range of PO2 becomes the safe margin. So this part becomes our safe margin for clinician to identify the wellness of your patient. So whenever you see patients with oxygen saturation between 90 to 100%, then you know that even if the PO2 drops slightly, the saturation will not change as much. But if the PO2 drops down further than that, and then it can decompensate your patient. So now we already know that the PO2 in lungs normally sits around 100 mmHg, where usually equals to 100% of oxygen saturation. You can see in this graph here, 100 on the y-axis, and 40 mmHg of PO2 in tissues. So basically we have 75% of oxygen saturation in body tissue. So this 25% difference are actually the amount of oxygen released to the tissues by the hemoglobin, and this is known as the functional oxygen delivery, which is the amount of oxygen needed by the tissues. So the remaining 75% of hemoglobin with bounded oxygen will be circulated and refilled at the lungs. So why do we need 75% filled with oxygen? It is to allow and help our body to pick up more oxygen when they reach the lungs, who has a higher PO2. Supaya so that your body doesn't decompensate and keep on losing the oxygen because of the nature of the hemoglobin. So therefore, in conclusion, we can say that at low PO2 of less than 15, there will be low affinity for oxygen, causing minimal binding. And this happens at the venous blood, so between the tissues and the pulmonary vein. At PO2 or between 2 to 60 mmHg, there will be a steep curve resulted from the positive cooperativity, causing a rapid oxygen loading and unloading depending on which sides they are. So this happen between the arterial blood, between pulmonary capillary and the body tissues. So at PO2 of more than 60 mmHg, it becomes a plateau phase where the hemoglobin are already full. So once the equilibrium have achieved at the pulmonary arteries. So the 25% gap is equivalent to the oxygen delivered to the tissues. All right. So moving on to the next part. So these are factors that can influence the hemoglobin affinity to oxygen. So at the tissue level, there will be increase in PO2, increase in hydrogen ion, increase in the temperature, so which resulted from tissue respiration or metabolism. So these factors influence the hemoglobin oxygen curve by shifting themselves to the right or to the left. So shifting by having this increase in carbon dioxide, hydrogen and temperature, shifting to the right means that there will be a lower affinity to bind with oxygen. The attractiveness of hemoglobin to oxygen will be lesser. Therefore, the hemoglobin will release more oxygen. So this condition is known as the Bohr effect. So where the hemoglobin affinity to oxygen becomes lower due to presence of these factors. So this effect helps the body to optimize its oxygen delivery to metabolically active and acidic tissues in order to maintain the homeostasis. So you can see from this graph, from the bottom one, the red, yellow and blue one, if it shifts to the right, it means it reduces affinity to oxygen, the tendency to release. If it shifts to the left, it means it has higher affinity to oxygen, where it tends to bind to oxygen more. So now, the Bohr effect, in conclusion, helps to promote oxygen release where it is needed. So usually at the tissue level. So these are the overall factors that can influence shifting to the right and shifting to the left side. So now, let's look at this case of carbon monoxide poisoning. So we have this 45-year-old construction worker with carbon monoxide poisoning. So how does the carbon monoxide affect oxygen dissociation in the plasma? So with carbon dioxide monoxide poisoning, so carbon monoxide presence in blood plasma, the hemoglobin will favor the carbon monoxide rather than the oxygen. So it likes the carbon monoxide more than the oxygen. So therefore, they will compete with the oxygen irreversibly to bind to the hemoglobin. So once the carbon monoxide bound hemoglobin, the oxygen binding sites will change its shape, making it more difficult to release the already bound oxygen, which means the previously bound oxygen on the hemoglobin will not be released, where it will be bound very tightly to the hemoglobin. So hence we can say that the oxygen carrying capacity will be reduced in carbon monoxide poisoning. So hence this oxygen dissociation curve, so these are the factors. So then you can see here the oxygen, so the oxygen dissociation curve will shift to the left. So to the left, where it bound more tightly to the oxygen. So looking at this graph here, the effect of carbon monoxide to oxygen carrying capacity depends on the percentage of carbon monoxide levels in the blood. So the higher the percentage, so the lower the oxygen saturation will be. So the lesser the carbon monoxide is in your body, so the higher the oxygen saturation will be. Okay, so that's why kalau patient tu dah have a prolonged carbon monoxide poisoning, therefore usually it's unlikely for us to help reverse this condition, as the PO2 will become very low. Despite giving a higher amount of oxygen, the carbon monoxide will still be preferred by the hemoglobin. So usually memang meninggal lah this patient. So now once the oxygen has been delivered to the body tissues, the hemoglobin will now pick up the carbon dioxide so that they can be transported back to the lungs. So this carbon dioxide is transported in these three ways, but mainly as the bicarbonate ion of 60%. So the bicarbonate ions are formed through the conversion of carbon dioxide, you can see from this equation, from the cell body into hydrogen ion and bicarbonate ion. So these are the principles of carbon dioxide transport. So this chloride will enter the RBC. I'll show you a picture. So in this picture at rest, so this slide, it shows the pathway of the carbon dioxide after being produced by the cells, where it will dissolve through the interstitial space. Okay, the interstitial space, then it goes to the plasma. Okay, belum. Okay. Wait. Go back skip. Tak nak pula. Okay, so I cannot buka balik the previous slide. So now, so if you can see back the slide, the previous one, the carbon dioxide will increase or raise the partial pressure of carbon dioxide in the blood. Then this increase in partial pressure of carbon dioxide initiates the pickup mechanism of RBCs for the carbon dioxide. Then this usually happens at the venous level. So therefore, then you can see from the other picture, at the alveolar level, the dissolved carbon dioxide in RBCs will be transferred to alveoli together with the dissolved carbon dioxide in the plasma. So, and then the hemoglobin carbon dioxide then will be reconverted into dissolved carbon dioxide as well. Then reverse chloride shift will happen at the alveolar level to maintain the electrical neutrality. Kalau dekat tissue, just now we have the chloride shift, where the chloride will enter the cell to maintain the neutrality. But at the alveolar level, the chloride will now be shifted outside, external to the cells in order to maintain the neutrality. So in this slide, you can see that previously we talked about the Bohr effect, where it helps to unload the oxygen to the cells where it's needed at the tissue level. So, but however, in the lungs, the higher PO2 will cause Haldane effect to occur, where it promotes the carbon dioxide release and oxygen loading to the RBCs. So kat bawah ni salah type the Bohr effect promotes oxygen binding kan. So ni salah, the Bohr effect helps to unload the oxygen. So that's why through this presence of Haldane effect, therefore you can see that the carbon dioxide dissociation curve is linear, unlike the oxygen curve, unlike the hemoglobin oxygen curve, where it is sigmoidal. So through this effect, the higher PCO2, the lower the content of oxygen, given the lower the concentration of the carbon dioxide content in the blood, secondary to the Bohr effect, where it helps to unload more oxygen from it. Okay, so the higher the PO2, there will be a lower carbon dioxide concentration. So we can say that the oxygen loading helps the carbon dioxide to unload based on these two effects, Bohr effect and Haldane effect. Now getting back to our original case or our patient. So why do this patient becomes breathless despite breathing rapidly? So these are the basic 6 concepts that you need to understand, where the presence of pulmonary edema will help first increase the membrane thickness for the gas diffusion to occur, and therefore there will be decrease of diffusion of gases in the alveolar, especially oxygen. Hence, it will reduce the arterial PO2 level, and compensatorily, it will be detected by the chemoreceptors. Hence, it will compensate through increasing the ventilation effort. However, with the existence or the ongoing presence of pulmonary edema, the increase in ventilation effort do not fix the problem, because the main problem lies in the diffusion part. So with this diffusion problem still persisting, despite tachypneic, this patient remain having a low oxygen saturation. So therefore, this the summary of the lecture content. So all the best for your exam, and I apologize for late uploading the slides. So thank you everyone.